Good evening, everybody, and special good evening to our students who are here to attend the ICA PG assembly session today, which is so very important for the students. And we have specially introduced this topic for our students. So something about the college that you would all like to know is that this Indian College of Anesthesiologists, which is academically active, very active, and is concerned only with the academic part of the anesthesia specialty. We are holding weekly webinars, and today is the 176th webinar that we are going to hold, so which we are very proud of it because we've been holding it every Wednesday for the last 2 years, and soon we will be completing 200, which is going to be a remarkable. We do all sorts of sessions in all specialities, and this ICA PG assembly that we have started is very important and very much appreciated by the students. So for this, we have this very interesting yearbook of anesthesiology, which we are publishing every year. And this November, just last month, we released the 13th edition. And this is very much appreciated by the students and by all anesthesiologists. And I request you to buy a copy from marypustak.com, where you can get it at a very subsidized rate. And the topics are so new and so valid and such important latest ones that it will be a treat not only for the consultants but also very important for the students. So this you can purchase. The other thing that I was telling you about is the PG assembly, the case discussions that we do with very, very senior doctors as your moderators. And today also we have very senior doctors who are actually the examiners who are going to be conducting this case. And today we have Dr. Madhusudan Upadya, and he's the professor of anesthesiology, and he was the former head of Kasturba Medical College, Mangalore. And he is a very, very renowned anesthesiologist, very academically efficient and very profoundly known to all of us. So we welcome Dr. Upadhyay. The other moderator is Professor Rekha Varghese. She's a professor at Amrita Institute of Medical Sciences, and her area of interest are GI, urology, pediatric, ENT, and surgery. So she's going to be the other moderator, and our students, of course, will be introduced by Dr. Upadhyay. Dr. Upadhyay will take over from me, please. And of course, the PG assembly has a long case of 40 minutes and a short case of 20 minutes. So I request Dr. Upadhyay to please start the proceedings of the assembly. Thank you.
Thank you very much, ma'am. It's absolutely a pleasure being a part of ICA PG assembly. And with the wonderful teachers around, I think we can also learn a bit. It's a mutual learning process. My co-examiner today is Dr. Rekha Varghese from Amrita, and the student who is presenting the first long case is Kritika Dwivedi from Chandigarh. She is from the Government Medical College, Chandigarh. She is the third-year resident. Kritika, you can unmute yourself. Yeah. Since it's I presume that there are a lot of postgraduates logged in. For the benefit of the postgraduates who are going to take exams, obviously the long case discussion, when we were postgraduates, Dr. Rekha would agree, and when Jayashri madam also would agree that we never had a timer kept. It starts with the presentation and ends with whenever the examiner is happy with your performance, at least to give you a pass, if not the gold medal. But now we have a timer on, and long case in most of the places, including the national board exams, you have about 30 to 40 minutes. Therefore, we also will restrict ourselves to 40 minutes and try to mimic a situation where the candidate is taking exams and we too are the examiners. All right. If we have any issues, any questions, you may put it up in the chat box. And at the end of the session, we'll have a debriefing session, which might last about 10 to 15 minutes. And meanwhile, We'll also take the questions which are put up by the students. We will try to answer to the best of our knowledge. Dr. Rekha is into the liver transplant. Therefore, I think she's more qualified than yours truly. Therefore, the final question and answer session will be handled by Rekha for the first long case. Yeah. Long case, the dear postgraduates, when you present it as a patient with all the history, physical examination in detail. And we will try not to stop you when you're presenting, or as a postgraduate, it's your responsibility to make sure that the examiners don't stop you. The fluency should be there, and every time you are stopped and asked questions in the real exam scenario also, it means that the examiner is not very happy with the way you presented. Therefore, make sure that the examiner is not given any opportunity to stop you and ask questions. Therefore, and then we will have the discussion as it would happen with your case discussion in the department or in the exams. All right. Are you comfortable, Dr. Krutika?
Yes, sir.
Are we ready to start, Dr. Rekha?
Yes, sir.
Yeah. Krutika, you may present the long case just now. For the audience sake, obviously you have heard that it is a liver disease, patient with the liver disease posted for cholecystectomy, but that is only a guidance. Questions can vary, and we may give different scenarios too, just like in exams. Okay? Yeah, you may present, Krutika.
Good evening all. My name is Kritika Dwivedi. I am a PG resident in Government Medical College and Hospital, Chandigarh. My case is a 65-year-old female patient who presented with a chief complaint of pain and abdomen for the past 20 days, generalized itching for 10 days, and yellow discoloration of eye for past 7 days. History of present illness. Patient was apparently asymptomatic 20 days back, after which she developed pain, which was gradual in onset, colicky in nature, and intermittent in onset, and was maximum at right upper quadrant, and was non-radiating, and have no. Patient also complained of itching, which was gradual in onset, progressive in nature, and relieved on
We lost you.
positive history. Patient also give a Patient give a history of bulky clay-colored stool and loosening of clothes over past 4 to 5 months and reduced appetite and dark urine. There is no history of fever, abdominal distension, nausea or vomiting in my patient. Past history. There is no history of similar complaint in the patient or her family. There is no history of any long-term medication, type 2 diabetes mellitus, hypertension, epilepsy, thyroid or tuberculosis. There is no history of any drug allergy, no travel history or no upper respiratory tract infection history at present. There is no significant surgical history for my patient. Obstetric and menstrual history. Patient is para-3 life-free with all 3 normal general delivery, which were all uneventful, and patient have attained menopause at an age of 45. The personal history. Patient is vegetarian by diet, have regular bowel and bladder movement. She is homemaker by occupation and have no history of any long-term exposure to smoke. There is no history of smoking, alcohol or tobacco consumption or any other addiction. So to summarize this, my patient is a 65-year-old female patient with no known comorbidities, presented with pain abdomen, which was localized maximally to right upper quadrant for 20 days, generalized itching for 10 days, and jaundice, or we can say that yellow discoloration of skin for 7 days. Patient gave history of significant weight loss, loss of appetite, and passage of clay-colored stool. Now for the examination part. General examination.
History,
Patient.
When you complete the history, what is your impression, basically, based on the history what you have presented?
Based on my history, as the clay-colored stool, dark-colored urine, loosening of clothes, along with decreased appetite, my patient looked like a case of obstructive jaundice. To know the causes and differential diagnosis, we have to go for the investigations further. So based on this, other the patient can have cholestatic jaundice due to malignancy of periampullary, like periampullary carcinoma, head of pancreas, due obstructive jaundice due to obstruction of biliary system that include radiopolithiasis, any stricture, pancreatic involvement, or cholestatic hepatitis.
Yeah, when you are asked a question, it's always better in the exams that you will stick to the answering to the point instead of volunteering with more info as you just did. Okay, based on the history, with it goes with basically an obstructive jaundice. And what could be the causes for the obstructive jaundice? It might be another question itself. Therefore, obstructive jaundice, right? You go with the obstructive jaundice. But then did you take a history of alcoholism somewhere in the middle?
Yes, sir.
I missed
was
that
no history.
because did you?
Yes, sir.
Okay, I think we missed because your network is quite unstable. It becomes very difficult. That's what it was told to you, to use a broadband connection when you are presenting. That kind of hindrances shouldn't be there. You do a, okay. Yeah.
Sir, should I continue?
Yeah.
Hello. Yes, sir. Should I continue?
Yeah, please.
Sir, on examination part, general examination, my patient was a thin-built patient with a weight of 55 kg, height of 168 centimeter, and a BMI of 19.48 kg. The patient was calm, conscious, oriented to time, place, and person, and was sitting on his bed comfortably during examination. After taking patient consent, we have started the examination. Patient vitals include the blood pulse was 90 beats per minute, which was measured in right radial artery, which was regular, good volume, normal character, and have no radial or radiofemoral delay. The blood pressure of my patient was 128 by 68 millimeter of mercury, which was measured at right upper limb in supine position. Respiratory rate of my patient was 18 per minute at rest and was thoracoabdominal in nature. Now, in general examination, there was icterus present, but there was no pallor, cyanosis, clubbing, lymphadenopathy, or edema present. Systemic examination, patient abdominal examination. On inspection, abdomen of my patient was normal in size and shape. The umbilicus was inverted and centrally placed. All the four quadrants were moving equally with respiration. The skin of abdomen showed.
Would you like to mention something else when you talk about the general physical examination? You are presenting a case of presumably a patient with the obstructive jaundice. It's a patient with a liver disease. Therefore, head-to-toe examination has to be a part of your general physical examination before you move on to the specific organs, isn't it?
Yes, sir.
Yeah. What are the things you look for?
Well, as a patient of obstructive jaundice, we can look for xanthelasma in eye. There can be icterus present, and there can be icterus in my patient. There can be spider nevi or caput medusa or palmar arrhythmia in the arm, in the palm of my patient. I can.
Yeah, basically head-to-toe examination, right?
Yes,
yeah, you can go sequentially.
Yes, sir. So xanthelasma in eye, gynecomastia, caput medusa in abdomen, palmar arrhythmia in palms, or we can look for any distension, spider nevi in chest, and as there is chance of coagulopathy, so any bruising, petechiae, or noting a seam if it's present or not.
Anything else? Yeah, initially you said the patient has been oriented to time, space. It's fine because that's one of the ways you try to rule out early encephalopathy. I also, right? Yeah. Then something else when you go down from the face. Yeah, excoriation, fine. He has been scratching to glory. Yes. Further down. The gynecomastia in males, testicular atrophy in males. Otherwise, palmar arrhythmia, you said yes. Tender hepatomegaly, yes. That you can talk about that later. In the palms, do you look at something else?
Palmar arrhythmia. The palmar arrhythmia.
Yeah, you said palmar arrhythmia, yes, right. Anything else? When it comes to the hands, Do you look for something else? Something else.
Flapping tremor or aesthetics for
Asterixis. Yes. Why do they get
hepatic
asterixis?
yes, sir. The hepatic encephalopathy.
Encephalopathy straight away.
No, sir. Flapping tremor are seen because of increase. Seen in hepatic encephalopathy patients. So to rule out this, we can see if there is any flapping tremor in my patient.
Yeah, exactly. How do you look for flapping tremors?
So we will ask the patient to extend his hand, and then we are going to ask the patient to keep them straight for 5 minutes. And if the patient is going to flap his hand and there will be extension and pronation.
Yeah,
Extension and flexion at
basically
the
you have to be able to differentiate
that.
between the fine tremors versus the flapping tremors, right? Yeah. There's a wonderful book on pharmacology by Lawrence. He says never keep these patients next to a window because they might flap so badly that they might fly off. Okay, then what else? We'll talk about the asterixis later. Then they have loss of hair, right? You have to look for the loss of hair, especially in males. Then early encephalopathy, the patient will complain of altered sleep rhythm. Then beyond. And they have something else on the face. Something else on the face. Parotid swelling is a possibility, right? Then what else? Spider nevi, you said. Hepatosplenomegaly, yes, fine. Then
the yellowish discoloration of skin or caput medusae.
okay.
Yellowish discoloration of skin alone, or is it yellowish discoloration of skin alone?
No, sir, ma'am. First, it will involve the sclera, and later on, we will have yellowish discoloration of the skin. Other than this, there can be cheilitis or glossitis in around the lips of the patient. In this patient, if
are there any other condition where you get yellowish discoloration of skin?
there is carotenemia, where the patient is taking a high amount of vitamin A, beta carotene. We can also see yellowish discoloration.
Yeah, colored vegetables. Right. So in your general examination, when you came down to the legs, is there something in the legs that you need to see? Anything that would indicate the protein levels?
Then pitting edema. If there is any edema present, edema present or not.
Okay. Sir, you can please tell. So is general examination over now? Right? You basically looked for the signs of liver failure, and you look for signs for any, you look for the yellowish discoloration, you look for fetal edema, and that is what are the positive findings in your general examination? Yellowish discoloration alone, right?
Yes, and scratch marks.
And scratch marks. Okay.
Okay. Yeah. Carry on. Done.
Systemic examination in abdominal examination.
Can I ask what's the reason for the scratching that patient's complaining of?
Then it is because of pruritus. In the patient with obstructive jaundice, the conjugated bilirubin they get accumulated under the skin, and it leads to sensitization of the nerve ending. Because of sensitization of nerve ending.
Is it conjugated bilirubin?
Yes, ma'am.
Okay, go ahead.
Conjugated. It sensitizes the nerve endings there, because of which there is pruritus. It is seen only in obstructive jaundice because of conjugated bilirubin.
Bile salts. Okay. Bile salts.
The abdomen was normally in size and shape, with umbilicus inverted and centrally placed. All the 4 quadrants were moving equally and freely with respiration. The skin of abdomen showed multiple superficial excoriation. There was no dilated vein or abnormal pulsation or mass seen in during inspection. During palpation, the abdomen was soft on palpation, but there was tenderness present at the right hypochondrium and epigastric region. There was no palpable mass appreciated during palpation. The lower border of liver was palpable below the right subcostal region, which was firm and regular in consistency. There was no apparent hepatosplenomegaly. On percussion, there was tenderness was present in epigastrium and right hypochondrium region. The abdomen was resonant all over the central quadrant, but dullness was noted over the flanks and bilateral hypochondrium region, which was localized and non-shiftable. On auscultation, there were normal bowel sounds were present. Groinal region and external genitalia were unremarkable. On respiratory system examination, the trachea was midline, and on auscultation, bilateral airway entry was present on both sides. There was no added sound present. In the cardiovascular system, on auscultation, S1 and S2 heart sound was heard on four areas, and there was no added sound. In CNS, higher mental functions were normal. There was no focal neurological deficit present, and all the cranial nerve functions were intact. Now the airway examination, the patient is thin built. There was no abnormal faces noted. Both the nostrils were patent and there was no visible anterior to nasal septal deviation. The mouth opening was show inter-incisor gap of more than 3 cm. The mallymphatic reading was grade 2. There was no tongue or parrot deformity. The patient has multiple missing tooth and there was loss of buccal fat. Neck movement show full range of neck extension and flexion. The thyromental distance was 7 cm and there was a normal temporomandibular joint function.
You talked about abdominal pain and tenderness in your examination. What's the relevance?
When the patient was complaining of right hypochondrium pain during it can be because of cholelithiasis or cholelithiasis, in which the patient have inflammation of gallbladder that can lead to right hypochondrium pain.
Any other condition where you will have right hypochondrial pain related to liver?
In hepatitis, there can be pain. In case of cholelithiasis, there can be pain. In cholangitis, there can be pain. Or in case of any acute fulminant liver failure, patient can present with pain and fever at that time.
Basically, the tender hepatomegaly, right? Yeah, it can be acute hepatitis. It can be acute fulminant hepatitis. It can even be if you have enlarged liver with the right heart failure. Also, you can have a tender hepatomegaly. All right. Yeah. Okay. Then. Anything else? Clinically?
Investigation.
You said no mass is palpable. Why did you mention that over the right?
Then because obstructive jaundice can be also because of periampullary carcinoma, any periampullary carcinoma of the duodenum or the bile duct. As it is a retroperitoneal organ, it is not generally seen in palpation, but if there is other than that, there is pervasive sign because of in case of any carcinoma, there can be palpable gallbladder, which can be seen during the palpation.
It will be painless. Painless. Okay. Fine.
Yeah. When the diagnosis is at the end of the examination still remains fine on the per-abdominal examination, and then you have
investigations and
history-wise. Yeah, history-wise, it actually directs you to obstructive jaundice and nothing else there. But obstruction can be due to.
It can be due to.
We don't know. Yeah.
Yes, that's also I can be because of any obstruction in the venous system.
How will you investigate this patient?
When we are investigating a patient of a hepatic disease, we are going to look for first. We will do the complete blood count. The hemoglobin of my patient was 10.5. The TLC was 11,000, and the platelet count was 2.5 lakh. Now next we will look for LFT in a patient to look for if there is increased bilirubin. The bilirubin of my patient was total bilirubin was.
Did you look at the WBC count when you checked the
Yes,
CBC?
ma'am. Yes, ma'am. It was 11,000. We will look for the WBC count.
Okay, fine.
Again, LFT, I will do LFT for my patient because we are looking for a bilirubin, higher bilirubin, as there was yellow discoloration of sclera. My bilirubin of my patient was 3, total bilirubin was 3, and the conjugated bilirubin was 1.5 milligram per deciliter.
How much was the total and the conjugated?
3. 2 was conjugated and 3.5 was total bilirubin.
Okay. So how much is normal? Bilirubin level, normal levels?
0.5 to 1 milligram per deciliter is normal.
And generally, which fraction is more normally?
Ma'am, conjugated.
Pardon?
Conjugated.
Normally, which fraction is more?
Ma'am, conjugated bilirubin.
Normally, conjugated is more.
Yes, ma'am.
Normally, unconjugated would be more. Okay. Please go ahead.
Ma'am, other than that, I will get a coagulogram for my patient. The coagulogram report was time was
So liver function tests are over.
Yes, ma'am. Albumin, we will also go for ALT, AST. The ALT of my patient was 40 and AST was 35. The ALP was 27.5 and the albumin was 3.9.
So if your albumin was say 2, what would that indicate?
And hypoalbuminemia, it indicates that the synthetic function of my liver are deranged right now because of the disease.
So a chronic disease process. It will indicate a chronic disease process and not an acute process.
Yes.
And you said alkaline ALT and AST are normal, right?
Normal, yes.
So can you tell me a condition in obstructive jaundice where it can be higher?
And if it is it is because of cholestatic drugs and it is a chronic condition. In the case of any chronic obstructive jaundice, because of the effect of bile, because of the apoptotic effect of the bile salts and bile tissue, it can lead to hepatocellular injury. In that case, there will be increased level of ALP and ALT, which is demonstrated.
Cholangitis, coexisting cholangitis can cause rise in AST/ALT levels, right? Okay. Did you mention about alkaline phosphatase?
Yes, ma'am.
How much was it?
27.5.
That's also not raised.
No.
So what is the importance of looking at alkaline phosphatase in obstructive jaundice?
Alkaline phosphatase shows the excretory function. It is present in the canalicular membrane of liver. So it shows it is increased in case of obstructive jaundice because it is secreted in the bile. So whenever we are looking for a cause of obstructive jaundice, there will be an increase in ALP level. And
is it only in liver disease that alkaline phosphatase rises?
No, ma'am. ALP is, ma'am, alkaline phosphate is also present in the bone, intestine, and the placenta. So it can be increased in other conditions like osteomalacia. There can be increase in third
How do you
trimester.
make sure that your patient it's high because of liver issues?
And we will look for we also look for the increase in gamma glutamyl transeptidase, and along with it, if 5-nucleotidase level is increased, along with it, we will look for clinical findings that.
Okay, fine, right, go on.
The other investigation I will get for this patient will be a coagulogram because it will also show the synthetic function of my liver. And the urine RM for this patient. In my patient, there was a urine bile pigment was present, but urobilinogen was negative in urine RM for this patient.
So how do you explain that?
Then because only when in bilirubin metabolism, the conjugated bilirubin being water soluble, it will go when because of obstruction it cannot go to the GIT system, so it goes through the blood into the kidney. That is responsible for the dark color of the urine and presence of bilirubin in urine.
So what is responsible for the dark color of the urine?
Then urobilinogen. Urobilin.
That is responsible for the normal color of
normal
urine.
color, and bilirubin is responsible for the dark color. of urine.
Conjugated bilirubin.
Conjugated bilirubin is responsible for that.
So whenever there's an obstruction, you're saying bile salts as well as conjugated bilirubin appears in the urine, right? That's what you're saying. Without any urobilinogen being there, right?
Yes.
Okay. Okay. So you mentioned that you look at the coagulogram. Is that what you said?
Yes,
so
ma'am.
what do you expect? Do you expect it to be altered?
Yes, ma'am.
What?
No, with these
Ma'am,
investigations which you have reported till now, LFT almost looks normal, right?
Yes, ma'am. Sir,
Yeah.
I will also get the RFT of this patient because there are, in case of obstructive jaundice, there are high chances of involvement of renal system. So even in my management and pre-op optimization, I want to look at the level of serum electrolytes and uracretin of this patient, which was normal in my patient.
Can I ask you why again, I'm just repeating the same thing. Why did you look at the coagulogram? What did you expect it to be?
Ma'am, coagulogram show the liver is synthesizing most of the coagulation factor of our body except 3, 4, and 8. So by looking at the level of, looking at the coagulogram, I can get the if there are enough coagulation factor are synthesized or not. I can look at the synthetic function.
Okay.
I can look if my synthetic function is intact or not.
So, in this patient, most of the liver functions, like your liver enzymes, alkaline phosphatase, everything appears to be normal. Is there any other reason other than hepatocellular dysfunction which will cause the INR to go up in this patient?
Then if there is
there is no bile in the intestine. There's nothing.
Because of this, ma'am, vitamin absorption. Bile is responsible for the absorption of fat-soluble vitamin like vitamin A, D, E, K. So because of this, there is no absorption of vitamin K, which is responsible for the gamma carboxylation of glutamate residue.
It's important to take that, right?
Okay. That's good. That's good. Right. Yeah.
Why do you expect that the renal functions might be affected in an obstructive jaundice?
Then, in case of obstructive jaundice, the bile pigments are released because of the damaged intestinal barrier function. The normal blood flora is going to increase because there is no bile salt, and they will lead to production of endotoxin. These endotoxin, because of because our tissue barrier function have been deranged, so these endotoxin can be released into our blood system, and they can reach our renal system. And bile pigment itself and the endotoxin both are nephrotoxic. Along with this, because of there are high chances of having decreased cardiac output and cardiovascular dysfunction that can lead to hypotension in this patient. Other than that, there are chances of nausea, vomiting because of obstruction.
Okay. Any other investigation?
To confirm the diagnosis, we can get an ultrasound for this patient.
From anesthesia point of view, do you want any other investigations?
Then ECG, I want to get an ECG and chest X-ray for my patient.
Blood sugar?
Blood sugar for my patient.
Did you mention the effort tolerance of this patient in their history?
Yes, max was more than 4.
Yeah. Basically, when you take a history and do a physical examination and then investigations, you have to be able to do the risk stratification, right? Starting with the ASA till the cardiac risk stratification, right? Yeah. Do you really need an ECG and a chest X-ray in this patient?
Yes, sir. Sir, this patient seemed to be having max more than 4, and a BHT was fine. But there are high chances of involvement of cardiovascular system in case of obstructive jaundice, because the bile salt itself have negative inotropic effect. They can also they can also lead to bradycardia, and there is also difficult, and they are also not going to have a response of exogenous catecholamine. So I want to have a baseline ECG so that I can know what is going on with the cardiopulmonary system of my patient.
The X-ray part?
The
Just
X-ray
X-ray part?
But in long term, like my patient history is only for 1.5 months, but if
Hmm.
there are chances of involvement of cardiopulmonary system, so to
Pulmonary?
if this patient would be of a longer duration, or if the patient is giving just history right now and have a history in past, there can be chances of cirrhosis, which can lead to involvement of our pulmonary system like hepatopulmonary.
That's all too far-fetched. In this patient, do you need a chest X-ray? My answer would be no. Yes? Yeah. When you keep thinking and when the patient ends up with hepatic failure, hepatocellular failure, maybe yes. Then you can think about hepatopulmonary syndrome, hepatorenal syndrome, obviously. Right now, it's a little too far-fetched. Okay, fine then. Now, because the investigations have to be kept to the basic minimum and the required investigations. You can't be getting all the spectrums of investigations done. Yeah. Okay, then. I think we are running short of time. Yep. Then, what else? Anything else you would like to investigate? The baseline investigations, the basic investigations, and then you do the LFT. Yeah, maybe an RFT because of yeah, maybe create. Yes, then ultrasound you need, fine, to confirm the diagnosis from the surgical side. Then
If in my case, the ultrasound there was no palpable rectoperitoneal mass was seen, but later on when they have done the CT scan, they found the rectoperitoneal mass that was involving the periampullary area. So if the diagnosis cannot be done in ultrasound, we can get for a higher investigation like CT abdomen.
okay. Yeah, we'll keep it simple cholestatic jaundice with maybe the patient has a cholecystitis and then a patient is posted for cholecystectomy. That's what was given, right? We'll stick to that basically. Then beyond that, maybe we can build on what your findings have been. And this patient has had a short history, therefore it goes well with the cholestasis, right? And we'll stick to that. And this guy, this lady is posted for the cholecystectomy. You have two options, an open cholecystectomy and a laparoscopic cholecystectomy. Which one would you prefer?
Sir, I will go for laparoscopic cholecystectomy.
Any particular reason why not open?
Sir, in laparoscopic cholecystectomy, there will be small incision. Will be a small incision. There will be less chances of post-op pulmonary complication. Patient will be able to ambulate early. Patient will be able to go out of the hospital early as compared to an open case. Other than that, there will be no chances of post-op pain.
There are the advantages of a laparoscopic surgery. Done. Agreed. Then, what are the disadvantages of an open surgery? Have you done an ERCP or MRCP in the middle?
No, sir,
Is it needed? Is it needed?
Yes, sir, it would be needed.
Most of the times when you have a patient with cholelithiasis, it's always very sensible to do on ERCP and then just supinate the patient and do a lap chole with the same anesthetic, right? That's the practice basically. Yeah, the ERCP was done on this.
Okay.
Yeah, you have to do, right? ERCP bar MRCP. Yeah. Then any other advantages of any disadvantage of laparoscopic surgery in this patient?
Sir, in my patient, there is no such a disadvantage. But if there is involvement of obstructive jaundice, if there is involvement of cardiac system, so because of the insufflation of CO2, there are high chances of pressure on our cardiac and pulmonary system. That can be a disadvantage for laparoscopy.
Liver blood supply, there is no effect on the liver blood supply if it's a laparoscopic surgery.
Sir, because it will increase the intra-abdominal pressure and sympathetic stimulation, it will decrease the hepatic blood flow.
What is the hepatic blood flow basically?
The hepatic blood supply consists of two parts. It is supplied from hepatic artery and portal venous.
How much?
25% from hepatic artery is supplied, 25 to 30% from hepatic artery. This blood is oxygen rich but poor in
But
nutrients.
which one goes down when you do laparoscopy? When there is pneumoperitoneum, is it both the portal venous supply and hepatic arterial supply, or is it one of them which goes down?
The total blood supply, because of sympathetic stimulation, there is increasing hepatic artery blood flow.
Yeah,
Because it is
exactly.
supplied
It's
by
not-
sympathetic stimulation.
basically it doesn't contribute much, right? Therefore, yeah. Then, yeah, you would go in with laparoscopic cholecystectomy. Yep. How would you anesthetize this patient? Be brief, another 2 minutes.
Sir, for this patient, when the patient will be in pre-op, I should explain in pre-op, intra-op and post-op, or just in the at the day of surgery.
Mhm.
Sir, in pre-op, I will explain before a patient of obstructive jaundice, the stabilization should be done before the surgery. I will go in the previous day of the surgery. I will go to the patient. I will explain the procedure to the patient, that what will happen, what will the size of incision, when will be the patient able to, what will we will do for analgesia, what will be the procedure from our side, and what will be the procedure from the surgeon side. I am going to optimize the patient.
Size of the incision and all is not our headache, right? Yeah, the surgeon would show a short video of that. Yep.
We will explain our procedure. We will explain the patient how much, what will we do for the analgesia, how will we give the patient general anesthesia, and we will take consent. We will take a consent for general anesthesia with endotracheal intubation.
No, my question as a patient would be how much more damage you can cause to my liver with your anesthetic. I heard everything is metabolized in the liver. Every anesthetic is metabolized in the liver. How much more damage will you cause to me? Will I ever wake up?
Yes, sir. Sir, I will explain the patient that we have drugs which have very much less effect on the liver.
Okay,
There
what
are
is the choice of anesthesia right now for you when there is a laparoscopic cholecystectomy planned?
Yes, sir. So we will go for general anesthesia with endotracheal intubation with intermittent positive pressure ventilation. In this patient, when the patient will come in the OT table, after all the ASA gate monitoring attachment and maintaining the ambient temperature of the OT and putting 2 large bore IV cannula on the patient, we will induce the patient. First, we will do the pre-oxygenation. For
2 large bore IV cannula?
So 1 large bore IV cannula will be sufficient in case of cholecystectomy.
When you talk about laparoscopic surgeries, there are only 2 basic surgeries, laparoscopic surgeries. One is lap chole, the other one is lap appendix. All the others are considered to be advanced lap surgeries. These are the basic lap surgeries. Yeah. Then?
So, we will pre-oxygenate our patient for 3
No,
minutes.
is there any other option for you other than general anesthesia with endotracheal intubation?
High spinal.
I would say LMAs are my friends.
Yes, sir. And supraglottic area. We
Can I?
Yes, sir.
Can I?
Yes, sir.
Which one?
Sir, second generation LMA Procil. We can use LMA protector.
But still, anyways, this is very debatable, and we are not here to debate the pro and cons of supraglottic airway device for laparoscopic surgeries. But to be safe, I think the conventional teaching is to use an endotracheal tube in, and I think you have to stick to that. Even if you are pulled into an argument, you should stick to the safest practice, which is an endotracheal tube. Can you do it under regional anesthesia? That's what I meant actually.
Sir, we can do it under regional anesthesia.
What are the
We can
problems?
give thoracic epidural anesthesia with spinal anesthesia. The thoracic epidural anesthesia will give a good hemodynamic stabilization, and it can also be used for post-op analgesia of the patient.
Okay. Any other advantage of a regional anesthesia?
Excuse me, sir. 3 more minutes. 3 more minutes.
Yes, sir.
Sir, it
No, that's Anish.
Sir, it have a
Yes, sir.
it maintains the
Oh.
tissue perfusion of all the because of a good stable hemodynamics. It maintains the tissue perfusion of the major organ because of which there is
Now, if it is an advanced lap surgery, the best advantage is that there is sympathetic blockade and then there is unopposed parasympathetic activity, and therefore the bowels, they shrink. The space available for a surgeon to maneuver or manipulate is much better. Therefore, regional anesthesia is touted to be better than general anesthesia when it comes to advanced lap surgeries. Here, obviously, your position alone is good enough to push the bowel away from the operative field. Therefore, surgeons are comfortable with that, right? Yeah, but it can be done under regional anesthesia also. CSEs or just sole epidurals can be done, right? There are people who do it with spinal alone, but again, I'm not a great fan of doing it under regional anesthesia. What are the problems if I just try to do it with epidural or spinal?
Sir, during whenever the peritoneum will be stressed or any gallbladder will be stressed, there is chances of vagal reflex that can lead to bradycardia in this patient.
Yeah,
Or-
but pneumoperitoneum, they tolerate the pneumoperitoneum well?
Sir, in the case of gallbladder surgery, there is chances of shoulder pain in this patient because of
No,
it
it's
can
any pneumoperitoneum, they can have a diaphragmatic irritation and then they can have shoulder tip pain. That can be managed. But otherwise, it's very difficult when the pressure goes up to 15 millimeters, and it's very difficult for the patient to tolerate the diaphragmatic splinting, and they can retain more carbon dioxide just because their respiratory efforts are not good enough. With controlled ventilation, you can control it, right? You can monitor and manipulate the CO2 levels. Yeah, then GA, if at all you have to give GA, what would be the choice of drugs?
the first after the pre-oxygenation, I will use an opioid. I will use fentanyl for maintaining my analgesia at a dose of 1 to 3 microgram per kg per minute. After that, for induction, I will prefer propofol because I will prefer propofol at a dose of 1.5 to 2.5 milligram per kg because it maintains the hepatic arterial buffer response, or it have a shortest contact sensitivity half-life, and its clearance is not that much dependent on and have a high hepatic extraction ratio. So its metabolism is not much dependent on hepatocellular metabolism. So I will prefer propofol as my induction agent. And at the end of the induction point will be taken at the loss of verbal response, after which I will look for ventilation. If the patient is, I am able to ventilate the patient, then I will go for muscle relaxant, and my choice in muscle relaxant will be cis-atracurium, followed by either first choice will be cis-atracurium, the second choice will be atracurium, as they are not metabolized in the liver. They are metabolized by Hoffman elimination or tissue esterase. So I will prefer them for muscle relaxation. After muscle relaxation with the vagal mask ventilation, I will after that I will do under diastrophy. I will put an appropriate
yeah, but then inhalational agents.
Sir, I will prefer sevoflurane if I have a choice and if desflurane is present. My first choice would be desflurane, followed by sevoflurane, then iso, and after that I will avoid halothane.
It's out of practice in most of the countries. It has been banned.
Yes, sir.
For use. Yeah. Sevoflurane is your choice.
Sevoflurane is the choice.
Any added advantage? You said desflurane, if it is available, you would use desflurane. Any particular reason?
Because sir, it is not metabolized much. It has the least metabolizing rate in liver.
Are you worried about actually the metabolism of the inhalational agents, or are you worried about the blood pressures which might go down because of maintaining the depth of anesthesia and then further damage to the liver functions because of hypotension?
Then I'm more worried about the hepatoarterial buffer response, which is maintained by the SIBO.
Yeah, good. Yeah, Sanish, what are the options you have for post-op analgesia?
So we should go for multimodal analgesia in case of surgery. So for this, as we cannot give we should avoid paracetamol in this case because, but as my patient's liver enzymes are normal, so we can give
You
paracetamol.
really have to avoid paracetamol?
No, sir, depending upon the liver functions, if my liver functions are normal in this patient, and I can say that the history of my patient is only 1.5 months, so
Oh, it's
I
only
can give
the
paracetamol.
insurance agents who come and tell you, when I die, my family gets this much. You never say my liver, my liver. I hope your liver is all right. Yeah, never say that. Okay. Yep.
So I will go for multimodal analgesia. I can
Yeah.
give paracetamol to this patient. I can give
Now, how do you manage the paracetamol? Say there is altered liver functions.
if there is altered liver function, I can either decrease the dose of paracetamol or I can increase the duration. Like
Very good.
we can give 1 gram
That's good.
IV QI.
Yeah, I understand. Yeah, that's good. Really. Then what else other than paracetamol?
The NSAIDs like diclofenac I can give the patient, or in opioids I can give fentanyl in form of IV PCA. IV
Good.
control, patient control analgesia, and we can apply a pre-op thoracic epidural anesthesia.
Yeah, that's a little
Thoracic epidural for analgesia, and local infiltration. Local infiltration of local anesthetic can be done.
No, before that, before the surgeon finishes, can he do something?
In laparoscopic surgery, we can give fluid. Most of the pain in laparoscopic surgery is because of the carbon dioxide that is retained. So one thing we can do.
I thought carbon dioxide is an analgesic. If I retain carbon dioxide, I don't feel pain. Yeah.
So carbon it's metabolized into carbon.
Now,
Okay. Sir, the
madam
patient
is very unhappy. No, before the surgeon.
Irrigation.
Yeah, what irrigation?
Irrigation to remove the blood and.
Oh, yeah. Can the surgeon do something for the analgesia part?
The local,
can he infiltrate the bed of
liver in bladder
with local anesthetics, right?
Gallbladder 4/7 after removing the gallbladder.
That's not a bad option, basically. And local infiltration into where the port sites are, fine, absolutely, yeah. Then whole range of drugs you can use, as long as those drugs are not metabolized by the liver. Paracetamol, you either increase the duration between the dosing, or you reduce the dosing. Yeah. Okay. Epidural is a little too far-fetched for, but I will tell you, if your surgeon has the habit of inflating too much of carbon dioxide, and if he exceeds the pressures, allowed intra-abdominal pressures, the patient will have diffuse peritoneal stretching and the patient is very uncomfortable. Then you may need more dosing of narcotics also. Okay. Yeah, madam. Rekha?
Yes, sir. I think that's fine, sir. So only thing is in obstetric jaundice, did she mention about hydration part? I didn't catch that. But...
Yes, in obstetric jaundice, because there are chances of the patient can complain of nausea, vomiting, there can be decreased appetite, there can be electrolyte disturbance. So we will look for the hydration. We will start the hydration of patient in the pre-op. First, we will maintain adequate hydration. In the pre-op day, we will start the patient. If the patient is not able to take food orally.
So hydration, dehydrated patient is not good from 2 points. At induction, you can have hypertension. You said because high bilirubin levels are going to affect the heart, and also dehydration patient with dehydration is not good for the kidneys either. So you need to hydrate this patient well before you take, ensure good urine output.
Excuse me, sorry to interrupt.
Yeah.
I think we can wind up the case presentation part and proceed with the next part, that is debriefing about the case discussion.
Sanish, we have time till 9, right?
Yeah.
Okay. Okay. Yeah.
We have Dr. Lakshmi also joining us.
Oh, wonderful.
MS.
She can come live, I think.
Yeah, I
Yeah.
am live.
Oh,
I'm not
hi.
sure if Kritika is going to be
Hi.
very happy with me being live. That's a problem. So, Kritika, you mentioned something about all your discussion on obstructive jaundice, right? Did you get a sense of what was happening? This is a patient who's probably having CBD stones and an obstructive jaundice, which is why we are talking about an ERCP and an elective cholecystectomy. So if you were to look at a patient coming for obstructive jaundice and you're looking at a set of investigations, does the level of bilirubin mean anything to you? Does it give you a clue of the etiology? Are you worried about any particular level of bilirubin? And how are these levels? Dr. Sanish, am I supposed to give her a feedback or can I ask questions?
Yes, basically like a debriefing session.
Okay, so see, I don't understand the meaning of debriefing, but I'm going to
Lakshmi, it's
persist with
all
this
right.
question.
It's all right. You can ask questions, no
So you
problem.
please tell me how the bilirubin levels actually matter to you, and then I will debrief. Yeah.
Ma'am, increased bilirubin, it acts as a prognostic factor of for my patient. If the bilirubin level are high, there are high chances.
What is the meaning of high? What are the adverse prognostic factors in obstructive jaundice?
Ma'am, in obstructive jaundice, that prognostic factor includes age of patient is more than 60 years. If the serum albumin level is less than 3, if the serum bilirubin level is more than 11 gram per liter, if the
Correct.
hematocrit patient is less, and if there is azotemia or involvement of renal.
Right, right. So what level is 11 the demarcating factor? If your patient came to you with 35
prognostic
milligrams,
factor.
of which 30 milligrams was direct, what would your concern be?
And the creatinine clearance, it said that with increase in bilirubin can affect almost every system. In the case of cardiovascular system,
So when and how does bilirubin affect the cardiovascular system? You've been saying it, but you don't really. Have you seen any obstructive jaundice like that? No, because patients are usually intervened, right? If the levels of bilirubin are high. So based upon the levels of bilirubin, do you get an idea of the etiology of the jaundice? How would you differentiate a malignant from a non-malignant cause of obstructive jaundice?
and in malignant there is a painless and progressive increase in the
And
level,
higher levels of
and
bilirubin.
higher level
Okay.
of bilirubin.
Okay, I'm going to stop here, Kritika, and just take a minute of debriefing. So I think you went about your history rather. I think you've done a great job of answering. I'm not sure if I would have done so well as a postgraduate. I just felt at points you were just off. You were saying things which didn't fit into a total clinical picture, right? And just one thing that I always feel strongly, and in fact, I think I texted Dr. Madhusudan and also, when you have a pure and straightforward obstructive jaundice, which is presenting early, we usually don't talk of cirrhosis and CLD, usually, right? So you need to demarcate those two things. There's a two different cases. One as obstructive jaundice, two as cirrhosis. And in a straightforward pure obstructive jaundice, presumptively liver functions are normal, right? And here I would have liked you to say if the jaundice levels went higher, if she had had any interventions, right? For any treatment of jaundice, because they say when the levels of bilirubin go high, there is a PTBD or some kind of drainage to get the levels down because they won't operate with high levels, particularly for a major surgery. ERCP, CBD stone, and lap chole is quite okay. Your description of how you elicit asterisks was a little off the mark. Okay, I think you've not done it or you don't know it, so you can please check on that. When you mentioned so much about radial artery, peripheral pulse, regular in rhythm, volume, no radiofemoral delay, are you actually looking at every patient with a coarctation to talk about this? You know, sometimes what you say has no relevance at all with the history that you're presenting. Then your pathogenesis of the renal dysfunction and obstructive jaundice, I thought was not completely correct. Right, this is actually an osmolar load onto the kidney, and that is why hydration remains the cause. The inflammatory markers actually comes from a disordered lipid metabolism in obstructive jaundice. There are abnormal circulatory apolipoproteins, which is why when you release the obstruction, you get a whole lot of problems. And probably that's something you need to know about. Choice of anesthetic, I think that I missed that part about pre-medication. So would you pre-medicate a patient or not with obstructive jaundice? Supposing you had the same 65-year-old lady, CBD stone, ERCP done today, posted for lab chole tomorrow. Bilirubin levels are 15, direct is 12. She's anxious, she's hypertensive, and she's diabetic. So what will you give her? Would you give her or you won't give her any anxiolytic pre-med?
I will try to avoid giving anxiolytic, but if I have to give the patient is quite anxious.
No, what is when do you decide if you have to or if you don't have to? You're the doctor. You're the person seeing the patient, not me. So what would worry you as to give or not? You find a patient anxious. So if you would, what would you like to give and why?
If the patient is quite anxious, I will give the patient low dose of alprazolam or oxazepam. I would avoid
Do you have oxazepam at your center?
No, ma'am, alprazolam. We give alprazolam in our center. So I will
So
give
you said
0.25.
oxazepam. So I'm the tough examiner. You have oxazepam in your center?
ma'am.
Then why are you saying oxazepam?
I will give
Right.
alprazolam, ma'am, 0.25.
So why are you worried about overdosing anxiolytic?
Ma'am, because they are going to be metabolized by the liver, and because
Everything is metabolized by the liver.
then they can lead to sedation and respiratory depression.
Everything
and,
leads to mild sedation. Sorry, I won't take you there. I'm supposed to debrief. Okay, so the etiopathogenesis of renal failure and obstructive jaundice needs clarification. There is an article in 2021. Okay, I can share it with Sanish and in the group later if you wish. Choice of induction drugs. Yeah, inhalation agents. I think Dr. Madhusudan got you there. And I think analgesics, nobody puts an epidural for a lap chole, right? And then you should be more emphatic about the choices of analgesia. There's so many available: a TAP block, a subcostal block, a rectus sheath block, an erector spinae block. They're so popular these days, right? And you wouldn't want to do an epidural for these kind of cases. If I were the examiner, I would have asked you a lot more questions on what happens during laparoscopy. Unfortunately, fortunately for you, I'm not. So I think that was it. It was pretty well done. And my only thing as an examiner, I felt that you really weren't in the center of the clinical picture, but then I'm talking after so many years of experience. Otherwise, it was very well done. You didn't even struggle for one answer. Did you see any YouTubes of this? Of obstructive, इसलिए मुझे पता था. ठीक है, okay, but well done, very well done. Dr. Sanish, I hope I haven't overstepped time.
No, yes. Madhusudan sir?
I'm
think
here.
he's
I'm here.
Dr. Rekha?
I'm here. No, I'm here. Yeah, done.
Yeah.
I think she has done a good job, as Dr. Lakshmi pointed out. Kritika did a great job. I thought I would catch her with the liver cell failure signs, symptoms in the beginning, but then actually Lakshmi madam was quite critical. She said, "Why do you ask this kind of?" And so I stopped that.
I didn't mean to.
No, I know. I was just joking. Lakshmi being what she is, her actually the debriefing was much better than our session, I think. Thank you so much, Dr. Lakshmi. And Rekha has been fabulous. Kritika, keep it up. At this rate, you should not have any problem in passing your MD with the flying colors. But only thing is, when you have a case scenario, as I said in the beginning, we have a timer on. But when we took exams, there was no timer. And you do the case discussion and that towards the end, give different scenarios and then go deeper. And in our time, there was no liver transplantation. Now we can talk about liver cell failure, hepatocellular failure, and then you can go into liver transplant also. There's no end to how much can be asked, but the time is a constraint. You did very well in the available time. And if there are any questions in the chat box, I think we can take it up, Dr. Sanish, before we move on to Kritika, don't leave. Wait. Before
So far, no questions, sir.
No questions. Is there anybody
Yeah.
on the other side, or it's
Yeah,
only
yeah,
us?
definitely. Yeah, today we have a good crowd. Yeah.
Just joking, just joking. Yeah, it's nice. Kritika, now I think you can mute yourself. We'll bring on board Krishna. Dr. Krishna, are you there?
Krishna is there.
Hello, Dr. Krishna.
Sir?
Yeah.
Sir?
No, I can't see you anywhere. Therefore, I wondered whether you are there. Are we ready for the post-tonsillectomy bleeding? The thing is, let me confess in the beginning that it's hardly a case discussion when you have exams, because you can't get a case of post-tonsillectomy bleeding to the examination hall. But the issue is, it's a sure short note question for you people in the exams, and if one step you falter and you may not get a live child back. Therefore, it's mandatory that even if your surgeons are very good, you may still end up with having a patient with post-tonsillectomy bleeding. And clinically, it is important, and practically, obviously, sorry, in the theory, it's important, but in the practical life too, in your lifetime, you will come across a few cases of post-tonsillectomy bleeding. Therefore, it's quite important to know how to manage, how to recognize, and how to manage the post-tonsillectomy bleed. All of us would have had these cases in our lifetime. Yes, Dr. Lakshmi?
Yes, of
bleed,
course.
yeah. And Rekha? Yeah, therefore, it's better that you are prepared for an emergency like this. All right. Yeah. Will you present when it's a short case? You only talk about the positive findings and nothing more.
Good evening, all. I'm Dr. Krishna PH. I'm doing my third year residency in the Department of Anesthesiology at Regional Cancer Center, Trivandrum. And about my case, it's a 5-year-old boy studying in 3rd standard, and the informant is mother, and the information is reliable. And he underwent
studying in utero.
Exactly. 5 years and studying in class 1, not 3.
8-year-old. It's 8-year-old.
Okay.
The patient underwent tonsillectomy 6 hours back, which went uneventful. Now presented with a coughing with sputum of 2 episodes, cough mixed with the sputum, 2 episodes. And there was a mother also noticed an increased frequency of swallowing also. And on examination, his pulse rate is 110 per minute with BP of 90/54 millimeter mercury, and pallor is present. He is conscious oriented, and on airway examination, airway seems adequate, but there is fresh bleed in the oral cavity. He is posted for re-exploration.
Yeah. What would be your concerns when you have a patient like this getting ready for exploration, and maybe they want to ligate or cauterize the bleeders? What are your concerns?
The concerns can be classified as under 3 headings: related to patients, related to surgery, and related to anesthesia. First is related to patient. It's an 8-year-old boy. The physiology and as well as anatomy is very much similar to that of adult. He can be considered as a small adult only. But there are some
here. Like you have been called to the bedside of this patient. How will you assess this patient? You have been called because they suspect they need to take the child into the OT. So you have at the bedside. How will you assess this child?
I will take a brief history. What procedure that means tonsillectomy. He had underwent tonsillectomy, and what type of tonsillectomy he underwent. Whether it is a cold knife method or using diathermy or something. And then after the history, I will do any past history, any relevant past history like bleeding disorders or family history, bleeding disorders in the family. And about the anesthesia chart also, I will look what kind of anesthesia the patient underwent, like general anesthesia with controlled ventilation, the size of an endotracheal tube, whether there is any complication during the procedure itself. And I will assess the NP also, of course. And after that, I will do a brief examination, brief clinical examination, starting with the consciousness of the patient, whether he is irritable, anxious, lethargic, or even unconscious. I will do. Then I will assess the vitals of the patient, heart rate, blood pressure, respiratory rate, and also the other parameters like capillary refilling time, and ask mother about the urine output, whether the child has passed urine or not, whether it is concentrated or not, and whether I will assure that's.
Yeah, why are you so breathless? Take your time. In the exam also, you take your time and answer. But it was nice. You are very fluent. But few of the things what you said, they don't hold water, right? You said nil by mouth status. It's immaterial in this patient, right? Obviously, 6 hours post-surgery. When do you start feeding this child post-anesthesia?
6 hours. After 6 hours, I will start. We will start feeding with him with cold saline or
cold saline to the patient.
Sorry. Cold ice cream, preferably ice cream. Start with cold fluids.
Ice cream for the ice cream for the patient or for the anesthetist?
For the patient.
Okay. Therefore, this is just at the nick of time. Therefore, obviously, the patient would not be, and it is superfluous to say the state of nil by mouth, because the patient has been bleeding and has been swallowing the blood, right? He will not be nil by mouth in the strictest sense. All right? Yeah. Dr. Rekha was very clear. I just request you people to again answer to the point, not going beyond the limits, right? She asked, what are you going to assess the patient? What are the things you're going to look at when the patient, the given scenario is the post-tonsillectomy bleeding. Obviously, you expect the patient to bleed into the oral cavity, and the patient would be swallowing that blood. Patient will be coughing out that blood if he is conscious enough, obviously. And then you have to look at how volume depleted the patient is. Your concerns, when I asked you about the concerns, your concerns when you have to handle this patient, it's basically the patient is hemodynamically compromised, right? The bleeding, what you see, and the bleeding, what you don't see, are not commensurate. He swallows a lot of blood in less than what he spits out or what you see. Therefore, you have to look at the hemodynamics of the patient. 3D pulse, you said, yes, fine. You wanted to see whether the patient is conscious or unconscious. That's a little too much. He won't go unconscious with the little bit of blood and swallowing blood. Yeah. Be specific when you say what you look for, right? Anesthesia, what has been given? Yes, fine, you have to know. But it's only general anesthesia with the relaxant, right? And obviously, though there is a lot of things, a lot of articles in the literature about supraclavicular airway device, I don't think most of our surgeons are very comfortable when you put on SGAD and then ask them to do tonsillectomies. It's very difficult. Therefore, it's always an endotracheal tube in situ, inside. And obviously, the size of the endotracheal tube you have to know because
there is a chance of it is an airway surgery, so there is a chance of airway edema. So we have to choose a smaller sized endotracheal tube.
Exactly. And then there is bleeding into the airway too, and therefore there can be irritation, and therefore there will be edema, and then maybe you have to reduce the size of the tube. Right? Yeah, agreed. Then what are the other concerns?
The patient is just we have already given a general anesthesia, so there will be residual action of narcotic agents will be there. And also a patient will be irritable as well as hypovolemic. So there is a chance of hemodynamic instability during induction. So prior to induction, we have to hemodynamically stabilize the patient. So the resuscitation should be carried out along with from this first spot onwards. Resuscitation should be carried out throughout the procedure.
Yeah.
And of course, it's an airway surgery. There is a sharing of airway with the surgeons. So they will be placing Boyle Davis mouth gag. So there is a chance of endobronchial intubation, accidental extubation, kinking of the tube, etc. If they are using cautery, there is a chance of airway fire also.
What?
If they are using cautery, diathermy agents, there is a chance of airway fire.
I don't know. Lakshmi Madam can talk. I am shocked. Airway fires with the cautery? No.
So usually laser fires and
Yeah.
what's spoken about. Do we actually ever worry about fire using a cautery to control a bleed? I don't think so. Krishna. Yeah?
Unless you use cooking gas to anesthetize.
So probably fires are not an issue here. You definitely need to be cautious about the hemodynamic instability at induction. So how are you going to plan for that?
Dr. Lakshmi, just interrupting again. Did she need to arrange anything prior to taking the?
Yeah, of course. Yeah. Krishna?
We have to start fluid resuscitation. We have to establish one more IV line and start infusing crystalloid at 10 ml per kg crystalloid. And meanwhile, we have to send investigation blood sample for investigation, hemoglobin, hematocrit, PTNR as well as APTT, and cross-matching, and for keep ready PRBC 200 to 300 ml PRC.
Yeah,
Are you going to repeat the hemoglobin for re-exploration? I'm sorry, the PTNR for re-exploration?
Exactly. We don't.
We do hemoglobin, but we
Yes.
don't do PTNR. We expect it as being normal and leave it at that.
Yeah, most of the ENT surgeons, they do PTINRs and platelet counts before the patient is taken up for any surgery where there is bleeding into the airway. I'm personally not in favor of that, but still the ENT surgeons, they do get it done. Therefore, there's no point in repeating them just before you re-explore, right? And it will also take time for the reports to come. Therefore, let's not do it. Hemoglobin and hematocrit, yes, it is to be done. Because as I said, the hidden bleeding, which you haven't seen, you will know when you do the bloods, okay, when you do the hemoglobin, should be fine, yes. And it should be kept to a minimum. I think hemoglobin, and you would have already done the blood grouping of this patient. You have to do the cross-matching and you have to get the bloods ready, right? Blood ready, the cross-matched blood ready. Right? You would like PRBCs, or would you like to keep something else too?
Preferably whole blood if available, sir.
Okay. Whole blood. Is there any blood bank which releases whole blood nowadays? No, they're not supposed to. Yep. Yeah. Right now, PRBC should be good enough because the patient. What is the maximum allowable blood loss in this patient? You said the patient's weight is 22 kilos.
Initial hematocrit that we will get from a lab value, and the or initial hemoglobin minus target value, that is age, divided by average into patient weight, that is 22 into 70. That's the blood volume per kg for this patient.
How much it would be? How much can this patient lose?
Roughly about 10% of his body weight, which comes to about 200 ml.
What is the blood volume in this child who weighs 22 kgs?
22 into 70.
Yeah, which is how much?
That will be about 1500 ml.
Yeah, about
Correct.
1500. Yeah, right.
Right. Okay.
Yeah, if the patient has weak pulse, tachycardia, and the blood pressure has fallen, obviously that means that the patient has lost enough blood, right? You start the resuscitation on the spot, as you said. Good. What else do you keep ready inside the theater?
What is your choice of resuscitation fluid, Krishna?
It is normal saline.
Is that what you do? You do tonsillectomies at your center?
Yes, ma'am.
You do? Pediatrics?
Yes, ma'am. In medical college, for all this pediatrics,
You rotate through medical
go for
college, right?
medical college.
You rotate through medical colleges as part of your training?
Yes, ma'am.
Okay. So is that the fluid that they normally use?
Normally in pediatrics, we use ringer lactate here.
Why are you shifting to normal saline? Because it's a tonsillectomy bleed? Can I use colloid?
If the hemodynamics is not improving with crystalloids, initial fluid, initial bolus of crystalloid, or if there is a delay.
What is the bolus of crystalloid? How much will
10
you give a 22 kg child? Bolus? You said initial bolus. So what is the bolus?
10 ml per kg. That will be around 250 ml, 220 ml
Okay.
over a period of 10 to 15 minutes.
Okay, you could even give it faster if it better. Okay, so if you find no response, you will think of a colloid. Okay,
Colloid.
I'm not going to pressurize and ask you what colloid. Okay, go on. I think Dr. Rekha and Dr. Madhusudan will ask.
Now you said colloid, is it somewhere, Krishnarjun? For resuscitation?
Sir?
No, Lakshmi madam said she won't pressurize you, but I would like to know what kind of colloid before the blood comes.
I will go for 4% albumin.
Okay, good. Why not the conventionally available HESs?
It is not being used very frequently in our department, especially because of the chance of renal injury, anaphylaxis.
Before that?
What causes anaphylaxis? Starch? I don't think so.
No.
Coagulopathy, it will accelerate the coagulopathy.
Yeah, that
And
might
it
be
will increase the
that might be
bleeding.
one of the reasons, though it's a little too far-fetched when you
So
use
in
only
whom does it cause renal failure, Krishna? Will it cause renal failure in a 22 kg, 8-year-old undergoing tonsillectomy and having a bleed? In whom is it contraindicated? And are you aware of the dose for at which toxicity, I mean, or renal morbidity can occur?
About also 50 ml per kg.
Right.
50 ml per kg.
So what will you say? Like the patient's tachycardic, you've given 500 ml, and probably he's bled. His hemoglobin of 12, when you sent a lab, has come as 7. You've asked for blood, they're just cross-matching. How much of, can you give starch as a emergency measure?
Starch, if albumin is not available, I will go for starch.
Okay, how do you prepare 4% albumin, or you have access to 4% albumin?
No, I will prepare it using 20% mixing with saline. I will take a 500 ml saline bottle and discard 100 ml from it.
Okay,
100 ml from it.
Why are we talking about 4% albumin? Why can't I give 20%? You're already diluting the patient with a liter of fluid. What's your rationale when you're talking of 4% albumin?
If the 4%, 20% albumin, we'll be giving it very slowly in a titrated dose of.
You're talking about a semi-emergency, right? You have a hemodynamically unstable patient in the context of a bleed, right? Even the fluid you're giving fast. So the reason why we are giving 4% is it is iso-osmotic with a plasma. Not a great idea to dilute with saline because already the sodium content of albumin is high. I'd be cautious. Okay, right.
Yeah.
So you take your patient in, and Rekha asks, what would you like to keep ready?
Before the patient is wheeled in.
I will first check for 2 working suction, which is kept at bedside. Working tiltable table. I will check for anesthesia machine, the ambu bag or this manual self-inflating resuscitation bag.
Yeah.
and I will make ready the pediatric difficult airway trolley, and I will load all the necessary drugs in according to the weight of the patient for induction as well as maintenance, and I will arrange ET tubes of 5 and 5 cuffed endotracheal tubes of size 5, 5.5 and 6, and also 2 laryngoscopes with blades of size 3 and 2. And also I will arrange all the emergency drugs, fluid for resuscitation, IV cannula, and also I will set OT between at 20 to 28 degrees Celsius.
You said all the drugs which are required for induction and maintenance, what are they? Do they change? Do they differ from what you'd like to use otherwise? Say there is a child, the same child coming for tonsillectomy, and now for the re-exploration or ligation of the vessel.
I will load ketamine.
Any particular reason?
Because the hemodynamics will be preserved, because the patient will be having hemodynamic instability, and so
How
the
does
hemodynamics
ketamine
will-
preserve hemodynamics? How is it different from propofol?
It will release norepinephrine from the nerve endings and maintain the
What happens with
vascular
propofol
resistance.
which doesn't happen with ketamine?
At usual induction dose, it won't produce myocardial depression, vasodilatation.
Vasodilatation. Okay, the SVR is preserved. Okay. What is the dose of ketamine
Vasodilation,
for
I agree.
induction?
2 to 2.5 mg per kg
Intravenous.
intravenously.
Okay. But ketamine per se is a myocardial depressant. When it acts indirectly through the catecholamines, right? If there are no catecholamine stores to be released, then it is a myocardial depressant. Therefore, if the patient has been in hypovolemic shock for long enough time, obviously ketamine cannot be a choice of induction agent, right? Yeah. Okay, then you loaded ketamine and kept. Then
And succinylcholine I will keep.
is there any risk involved with the succinylcholine?
Less than 8 years, there can be chance of unrecognized myopathy. So the patient can go in for rhabdomyolysis as well as malignant hypothermia.
Okay. Anything else?
Other problems like hyperkalemia.
No, you have just extubated the patient and the patient is oozing out, right? Bleeding. You
6
have just
hours.
There can be chance for
6 hours.
6 hours, okay.
there can
6
be
hours?
chances of bradycardia
Because?
because of the due to scoline, because of the metabolite of scoline, that is the succinyl
Succinyl
monocholine.
monocholine becomes significant only when you use repeated doses of succinylcholine. I would have intubated with say atracurium, cisatracurium earlier for the tonsillectomy, and I have also reversed the patient with a little bit of anticholinesterases. And can you still use relaxant?
The succinylcholine action will be prolonged because the patient has already received neostigmine.
Yeah. But anyway, 6 hours is a safe window period. You may not have that kind of an issue. If it is much earlier, say couple of hours after the extubation, then there is a risk. Okay, 6 hours is a safe margin. Okay, then. Is there any other option other than succinylcholine for intubation?
We can use rocuronium also at a higher dose, that is 1.2 mg per kg. And we will be getting the intubation condition within 60 seconds.
Cisatracurium?
Cisatracurium at a higher dose, that is usual dose is 0.15 mg per kg, usual intubation dose.
When do you get the intubating conditions with 0.15 or with 0.2 milligrams per kg? Do you get the intubating conditions in about 60 to 90 seconds? That's also rapid enough, isn't it? Yeah, then what else do you keep ready other than these couple of drugs? Would you use narcotics or you won't use narcotics?
For analgesia, I will use narcotics.
Hmm.
Fentanyl at a dose of 1 to 2 microgram per kilogram.
Yeah. Whatever drugs you use, make sure, I mean, you do take a consent for maybe prolonged or longer duration of action, and then maybe you have to ventilate the patient, because it might be just go in, boil Davis mouth gag, and then they look at the bleeder and then they ligate it or cauterize it and come off. It may not take long time because it's a primary. What kind of bleeding is this? What post-tonsillectomy bleeding? What could be? How is it classified?
It can be primary hemorrhage, reactionary hemorrhage, or secondary hemorrhage. Primary hemorrhage occurs at the time of surgery. It is mostly due to the injury to the blood vessels. And reactionary hemorrhage occurs within 24 hours. It is due to slippage of ligature, closed clot dislodgement, or due to rebound hypertension. Secondary hemorrhage occurs after 24 hours up to 28 days.
It's not secondary. Therefore, it happens within the first 24 hours, and therefore it is reactionary. Right? Yeah, exactly. Yep. But you have to take a consent for a longer duration of ventilation. Maybe you have to place the patient in the post-op ICU with ventilation, right? He may not be.
So I would be cautious about the dose of fentanyl when I'm taking for a re-exploration. This is a child who's just 6 hours after extubation and has had a hemorrhage and is likely to be mildly hypothermic and maybe even slightly acidotic. So drugs are going to act longer. The fentanyl dose, I would probably be cautious with 1 mic or something and then titrate as per response. Right?
Yep. I agree. Yeah, then further.
Then I will shift the patient in left lateral position. And then I will shift the patient to our OT table, attach all the monitors and see for the baseline values. And I will pre-oxygenate with 100% oxygen for a period of I will pre-oxygenate for a period of 3 minutes. Then I will induce with meanwhile I will during pre-oxygenation I will give glycopyrrolate 0.2 milligram, and I will induce the patient with ketamine. If the hemodynamics are if he is stable, if his BP and heart rate is stable, I will induce him with ketamine. It is not stable, I will induce him with ketamine 40 milligram. Then
basically the classic teaching is that any drug, anesthetic drug, is safe in the good anesthesiologist's hands, in good hands. Therefore, if at all you are so worried about if at all you're too worried about the hemodynamics, you can still go in with the ketofol rather than just ketamine. Ketamine alone, and the dosage required might not be as much. Therefore, you should be able to use it. Okay. Ketofol is a great combination what you can use, but ketamine is not. If for the exam's sake, when you say ketamine, it's okay. It's not a crime to say that. But it's not such a wonder drug, as I said. If the patient has been hemodynamically compromised for quite some time, it might still cause harm, right? Yeah. If there are no catecholamine stores, it is a myocardial depressant. Yeah, you will, but use judiciously, and it should be okay. Then, no, I want to know the technique of your induction. That is more important.
I will go for rapid sequence induction and intubation with the cricoid pressure.
In a child expected, sorry, go on.
Then I will give succinylcholine 40 milligram and wait for 1 minute, or wait for 1 minute. Meanwhile, I will give small tidal volume ventilation with by adjusting airway pressure between 10 to 12 centimeter water. And after 1 minute, meanwhile, while inducing itself, I will ask my assistant to give cricoid pressure and deepen it once the patient is under. Then I will do a direct laryngoscopy and intubate intubate the patient with a cuffed endotracheal tube of size 5 millimeter mercury internal 5 millimeter internal diameter, and I will check for the tube position by different method, by the end-tidal carbon dioxide monitoring, by auscultation, and also by visible chest rise, and also
it's all easier said than done, because the moment you take the laryngoscope in your hand and look into the oral cavity, it is flooded with blood. The posterior pharyngeal wall is filled with blood, and there might be clots also, because over the last 5 minutes of your pre-oxygenation and drugs, and then you wait for the relaxation to happen and then take the scope, there would have been clotting also. Therefore, you will have clots, you will have fresh bleeding into the oral cavity. Life is not that easy there. Okay, you have to be prepared to get the airway cleared first. For you said you need 2 functioning suctions. I think it has to be there, right? You have to be extremely cautious. You said your assistant will lift it up. Who is that assistant you have? The cricoid pressure, you said you need an assistant to apply. Who is that assistant? Qualified assistant or?
It's a qualified.
Yeah, it's always better to go in with, see, by definition, this is a pediatric patient, right? And unless you are into pediatric anesthesia, you won't practice pediatric anesthesia without the help of somebody else. If you are into pediatric anesthesia practice, obviously you can, with some expert hands, you can. Otherwise, you need 2 qualified anesthetists. Okay? And that
So
too,
another thing, Krishna, is the cricoid pressure in pediatrics is controversial.
Yep.
So one, you really will not be able to apply it properly. And as very evident from your presentation itself that, it can never be done the way you're saying. You're saying you'll have them just start and increase the pressure as soon as you give relaxant. It never happens. So cricoid pressure in pediatrics is a controversial issue. Whether you would give assisted ventilation while you're pre-oxygenating, yes, you can, and very cautiously, to give you a little leverage, because when you're going to put that scope in, you're not going to be able to visualize the glottis. The other thing is you keep a tube size that is probably smaller than what was used in the morning. There's always a possibility of airway edema. And then if you have a choice of tubes, what tube, cuffed, uncuffed, microcuff, normal cuff, you need to mention. And what mark would you keep at the angle of the mouth in a 3-year-old child? This child is what, 5, right? How old was the child? 8 years.
8 years.
Yeah. So what would the mark at the angle of the mouth be?
At 16 centimeter.
How did you derive at 16?
By using a formula, h by 2 plus 12.
12. Okay, fine. Okay, so this is what it is. Cricoid pressure, no. Assisted ventilation, yes. And assisted ventilation given because you get a little extra seconds when you're doing a laryngoscopy. Okay?
Yeah.
Choice of fluid during procedure?
I would go for ringer lactate.
Okay, how much? Let's say you resuscitated from the initial hypotension. BP is now 90/60. Heart rate has come to 96. Surgeon has found the bleeder and cauterized it. And he's going to close very soon. Do you need to replace dextrose? What are the indications for replacement of dextrose in pediatrics?
In neonates, we will give dextrose.
How much percentage will you give in neonates? How much percentage will you give in an infant? How much will you give in an older child? Will you give dextrose for this child? Yes, no. And how will you give it?
Uh, 5% dextrose.
How?
5% dextrose mixed with the normal saline. That is
You love that normal saline, don't you? So there's something called DNS. Will you use that? So your answer is wrong. You only have to give dextrose. Yes, you do give in neonates. You give in children who are septic or have liver disorders, and children having a prolonged surgery supplemented by regional anesthesia. In this case, this child has been probably NPO and surgery and 6 hours, and then again, you need to be cautious. All that you need to give is about 1% dextrose. There are various ways of preparing. Roughly, for 24 ml of ringalactate, if you add 1 ml of 25% dextrose, you get a 1% solution. I only use the maintenance amount of 1% dextrose. Beyond this, I feel causes hyperglycemia, but each consultant's practice can vary. Okay, there's no 5% dextrose, and normal saline is not really so normal. It's a little more abnormal than you would believe. Okay, so we are okay with balanced salt, and we use a 1% solution. Now surgeon has finished. It's taken a total of 30 minutes. Heart rate is down 90, BP is stable 100/60, color is returned, and everyone's heaving a sigh of relief. Okay. How will you plan extubation, and how are you going to manage the complications after extubation? What are they? How would you preempt any complications that can occur after extubation?
So once the surgery is finished, I will do a laryngoscopy and do a suctioning of oropharynx as well as nasopharynx under direct visualization in the tonsillectomy position itself. Thereafter, I will check.
What about the swallowed blood that Dr. Madhusudan was talking about?
I will insert an orogastric tube under visualization, and I will try to suck out the.
Why do you need to visualize?
Because the instrumentation, the Ryle's tube insertion will further cause injury to the raw area of tonsil.
So how would you do it under vision?
By performing laryngoscopy, and I will introduce.
Okay. Is that how you do it? Have you ever done that?
Yes,
okay, so you empty the stomach contents. I'm not sure if you've done that. Okay, you empty the stomach contents. Then what are the other medications, pharmacological agents that you would keep ready at the time of extubation? What are the complications you anticipate?
I will keep ready propofol as well as.
I thought you keep neostigmine and glycopyrrolate. Why are you keeping propofol?
For reversal, I will go for neostigmine and glycopyrrolate combination. And after I will
put a Ryle's tube, you make sure temperature is okay, you make sure hemodynamics are okay. One point during any pediatric surgery, you need to measure blood glucose and make sure it's normal, right? Then you get ready for extubation. Now, you said you would load reversal, fine. It's been 40 minutes since the first, you've obviously given cisatricurium or atricurium after your schooling, correct? Yeah, no, you didn't.
Yes, ma'am.
So it's about half an hour after that, you're ready with your neostigmine glycopyrrolate. Then what else will you do? You said you'd keep propofol in anticipation of?
Laryngospasm, which can occur by the vocal cord, irritation of the vocal cord from
so you've done a suction, you've emptied the oral cavity of secretions and blood, you've given the reversal agent, the child starts taking breaths regularly, right? You look at a senior or colleague who is with you and you both decide to pull out the tube. And you hold a mask on the child's face and you initially see a EtCO2 waveform. After 15 seconds, you notice that the waveform is coming down. The BP is okay, right? And as you look at the child, you notice that there is a seesaw movement of the abdomen, and you also hear a kind of a crowing sound along the breath. What will you do? What do you think is happening, and what will you do?
I will increase. I will provide 100% oxygen, and I will open up the patient's airway by providing head tilt, chin lift, jaw thrust
Okay.
maneuver.
So you give 100% oxygen and lift the jaw and thrust the chin forward. And the saturation now comes from 90 to about 86. What do you do? You're on 100% oxygen. You're holding the child's chin and thrusting the jaw and holding the mask. The same seesawing continues then.
I will give positive pressure ventilation
Okay.
and see whether the
So when you give positive pressure ventilation, you're seeing the pressure waveform rise and fall, but the EtCO2 is not there.
then I will give propofol.
Now the saturation comes to 78.
Then I will give propofol.
Okay. How much of propofol will you give?
1 mg per kg propofol I will give.
Okay. How does propofol help in this situation?
Propofol will break the laryngospasm by propofol will suppress the airway reflex.
Okay. Right. So you give propofol. Now you slowly see that EtCO2 come, very, very small curve, and then it stops. Again, the seesawing continues. Now what do you do?
Then I will give.
Could you have given any medications before extubation that might have helped?
Lignocaine.
How much?
Lignocaine 1.5 milligram per kilogram.
At extubation. Okay. Anything else? You've done 2 intubations. There's been some trauma, some handling and pressure on the
Dexamethasone.
circuit. How much?
Dexamethasone 0.1 milligram per kilogram at the time of
That's a very low
inhalation.
dose. It's a very low dose. So we give 0.2, but the recommended is about 0.5 mg per kg. Anything else that can decrease the edema? Have you used nebulization of any drug that can reduce airway edema?
Nebulization, adrenaline.
How much? What percentage adrenaline and how much?
1 ml adrenaline diluted to 10 ml and we'll give.
Give how? 1 ml is what we use in CPR. So how would
Is
you give that
diluted
to?
I mean, 1 milligram.
Diluted to 10 and how much of that do you take? You take 1 ml of that, isn't it? 1 in 10, 1 cc, and you can nebulize, right? So you're trying to do all that and fit the nebulizer. Now the saturation drops down to 55. Now you also notice there's bradycardia. Heart rate is 48, saturation is whatever I said. How much did I say? 55, 60. Now what do you do? Your consultant has got a call and she's just walked away to some other room. So you're alone with the child. Now what do you do?
I will give atropine 0.02 mg per kg.
Okay, you
for
give atropine
bradycardia
and the
and-
heart rate increases from 48 to 56, but the saturation is going down further.
Then I will re-intubate the patient.
How? Is there something that can be given to break the very severe laryngospasm that's causing problems with oxygen?
Succinylcholine can be
Yes.
given at a dose
How
of
much?
0.1 to 0.5 mg per
0.5
kg.
mg. Okay, right, right. What is the position that you need to adopt when this child is shifted? So the child's spasm is over. You've given adrenaline nebulization. Now the respiratory movements are clean and saturation and heart rate are maintained. You now want to shift the patient to the recovery. What is the position that you would adopt and why? Not you, the patient.
The tonsil position. The
What is
patient
the tonsillar position?
Patient is in left lateral position with a forward slant of 45 degree, with the non-dependent hand under patient's back and dependent hand under patient's
Non-dependent hand on the?
Patient's back and dependent hand in under.
So he's what? Patient's back like that?
Or non-dependent hand can
The
be.
dependent hand
That's
is
a
under the
recovery
patient's
position.
head. And it has to be forward, no?
Yeah.
Not at his back. His back is here, behind him. Why are you
Yeah.
looking so puzzled? Have you ever put a child in tonsillectomy position?
Yes, sir.
And it is called
So the hand cannot go
post-tonsillectomy
to the
position.
back.
Krishna, you can't
Right?
call it a tonsillectomy position. Tonsillectomy position is what they adopt when they do the surgery. This is the post-tonsillectomy position, right?
Post-tonsillectomy position.
Tonsil
I think I
position.
also said that.
You said tonsil position. No, she
Tonsil
said tonsil
position.
position. Yeah, I think, Lakshmi, we are running out of time. Sanisha, after me.
Has he sounded the red flag?
Oh, a
Okay.
lot of times, lot of times.
Oh, okay.
But you
Okay,
are
I'm
in
sorry,
full flow,
Dr.
therefore
Sanish.
I couldn't stop you from.
Okay.
Because,
Okay, sorry. I
no.
generally
This is
find
one
it
of the most common complications you can ever get, the laryngospasm,
Yes.
when you anesthetize a pediatric patient. Therefore, you should be, and in the exam, you are also expected to answer about the Larson's point, right? Yeah, unless you answer that, it's not complete. The rest of the things you did well, Krishna. I think you are going to be a safe anesthetist if you practice whatever you have spoken. But I think only thing you have to remember is about the fluid resuscitation. Fluid resuscitation, I don't think there is any role for normal saline anywhere. Keep a watch on the sugar levels of a pediatric patient at all times. It's better, especially if after prolonged duration of anesthesia and fasting, and then post-op complication, duration of the post-op complication. I think you have to keep a watch on the sugars. They really need sugar as a substrate to survive and metabolize. Keep it in mind. Normal saline, there is nothing normal about normal saline, as Dr. Lakshmi has said, and it's common. I mean, it is known. Therefore, don't you ever think about normal saline as a solution. When we were PGs, we used to talk about half strength of saline and then normal saline, 0.45 it is, and then we used to add some sugars and make our own fluids. But gone are the days. We talk about the balanced salt solutions. It could be ringer lactate. It could be the real balanced salt solutions, Cabilite or whatever. All right, you can look at them as the crystalloids to resuscitate. I think you did overall very good. Yeah, you can be proud of yourself. But any questions in the
So actually, some of the questions were answered during our discussion. There was one specific question to anesthetists in this case. I hope it's about post-tonsillectomy bleed.
Yeah.
I think we have touched upon that point too.
Yeah.
And from the initial part, can laparoscopic approach be planned in a patient with COPD, given already high PaCO2 values?
Ma'am has answered that question, I think.
No, but
Lakshmi,
they won't be getting this chat text.
Oh, okay.
Oh, I see. Okay. So yeah, you can do laparoscopic surgery, cholecystectomy in a COPD patient, simply because today the advantages of lap cholecystectomy seem to outweigh open at any cost. Of course, it depends upon the class of COPD that they are, what their baseline PaCO2 is, and how much their compensation. I would be more worried to see if there are any bullae, because during laparoscopy, the bullae can rupture and it might cause a tension pneumothorax. That's a question that is asked if you're doing laparoscopy. So be very cautious about bullae that you see on a CT or a chest X-ray. They may, or the COPD patients may need little more intense evaluation, including a chest CT before you take them up for a lap surgery. And their PaCO2, actually, they are adjusted to it. If they have a PaCO2 of about 45 or 48 or 50, the bicarb is already compensated. So you can allow a higher one. You will have trouble in getting them off. They may need to be ventilated for a short period of time or given a support of non-invasive ventilation. They may not come out and extubate as well as a non-COPD patient will. I hope that answer is correct, all the seniors in this group.
Yeah, that's perfectly all right.
Before we conclude, one concluding remark from all three examiners.
No, we've already been talking, so you're the only one who is not
exactly.
Yeah. Dr. Anish should be summing up because we've been talking.
No, only thing is I would say it has been a pleasure sitting with Lakshmi again. It's a wonderful experience sitting with her. And Dr. Rekha, I really enjoyed being with you here right now, because it was really nice. It was really nice. But all the students who are listening right now and who are likely to get onto the YouTube and go through this, I'm sure it helps you. Hopefully it helps you in your exams. And we too had a wonderful time doing it. Thank you so much. Kritika and Krishna, and you did great. Again, I had already told you, Kritika, and Krishna, you also did very well. Be safe anyways before you do anything. Even if you need help, be open asking for the help, because ultimately the patient has to be safe, right? Yeah, therefore, you will do good for yourself. Sanish and Jayashri ma'am, BRK sir, Baljit, thank you very much. And my only request is let us complete one cycle of case discussions for the sake of the postgraduate students on this platform. I'm willing to come back again.
Sure,
Okay.
sir. Dr. Rekha, concluding remarks from your side.
Oh, I don't have much to say. Actually, I think both the candidates did very well. They answered most of the questions, so I think they did well. Like sir said, they won't have a problem passing the exam.
Lakshmi ma'am?
Yeah, I think this is the first platform where, the question and answers, I'm told, were totally unrehearsed. Like I came after initially saying I won't be there, but I was told by my colleague, Dr. Rekha, that there was no question answer rehearsal. And all the sessions that I've done so far have always involved question answers, how to present, what to say, what slides to put. So I think the typical exam scenario is replicated here. And I'm actually pleasantly surprised that the candidates have done so well. It's not easy to sit in a platform where, there are hundreds perhaps of people watching you and be exposed to questions that you don't know what's coming. I think the candidates handled that part remarkably well without too much of stage fear. So congratulations, Krishna. I have a feeling that you probably don't rotate through so much pediatrics. That's my gut feeling. I probably I'm right, and probably you can excuse yourself for some of the lacunae which I thought were present. But otherwise, I think tremendous challenge, and they handled it so well. And Dr. Sanish, I think it takes courage to put this kind of platform and do it the real way exams are held. So thank you again for having me be part of it.
Thank you very much, ma'am. Actually, I wanted to give a sense of timing to the candidates as well. That's why I was pushing for the timer part of it, so that they should indirectly, subconsciously, they should be knowing that 35 minutes
they're taking
passed,
time.
and still I haven't reached an anesthesia scenario discussion. I'm still struggling around with bilirubin or whatever.
Yeah.
So that was one.
But I don't think Kritika struggled at all. We were taking her and she answered everything. And
So I'm happy to extend an token of appreciation from Indian College of Anesthesiologists to both the postgraduate presenters. Kindly accept this e-certificate of appreciation, which will be reaching you soon from Indian College of Anesthesiologists. This one for Dr. Kritika and this one for Dr. Krishna. I also thank the mentors from their respective departments, Dr. Manpreet Singh Dava, Dr. Halley from RCC Trivandrum, and Dr. Mary. Thank you very much.
Thank you, Dr. Sanish.
Thanks, pleasure.
Thank
I
you,
would
sir.
request
Thank you, sir.
Dr. Ishtiaq for a formal vote of thanks for this session.
Thank you, Sanish sir. It was a very enlightening discussion, and I'm sure all the PGs must have benefited from it. Thank you all the esteemed faculty and the students for this academic discussion. So our next discussion will be on the 6th of December. That will be again a case discussion of a patient for TURP with ischemic heart disease. Sanish sir, we can end the session here now.
Yeah.
Thank you.
Okay.
Thank you.
Yeah.
Thank you very much.
Thank you, and good night to everyone.
Bye.
Thank you, dear doctors, for your
wonderful presentation. So we are signing off for today, sir. Goodbye and take care to all.
Good night.
Thank you, sir.
Thank you all. Good
Thank you.
night. Good night.